All right. Good morning, everyone. Thank you for joining us for our next Public Health 101 session. Today, we're going to be hearing from Alicia Mahalikis, and she's going to be talking about how RIDO prepares for and responds to public health emergencies. So, Alicia, go ahead.
Thanks so much, Jen. Good morning, everybody, and welcome. I see many familiar faces in the audience, so hopefully I do my amazing team justice here. My name is Alicia Mahalikis. I've been at the department now for more than 18 years, and believe it or not, I started in the bioterrorism program when it was first starting here at the department and have never left that sphere. So our scope has changed over time in terms of all of the things that we now address beyond just bioterrorism, but it has been a wild adventure. So I know a lot of people are curious about how the department plans, trains, and responds to emergencies, and I should say, and exercises, excuse me, and then responds to emergencies. So I'm hoping to give you a little bit of flavor on who we are and what it is that we do. The secret sauce is all over this slide. It is the people who make the world go round, and they make the magic happen. So we have an incredible team, and our team is incredibly integrated across the department. So while we are responsible for sort of the backbone structure of how we plan, train, exercise, and respond, we work with partners across the department and utilize their subject matter expertise and the resources that they bring to bear, as well as the many external partners. So our overall mission is to create and promote a state of readiness and prompt response to protect the health of Rhode Islanders during catastrophic events and large-scale disasters and emergencies. I will say that we utilize all of the tricks of the trade that we are developing and testing for sometimes very small, just a few hours type emergencies, to much larger structures, including how we initiated our process for COVID, though it was a unique structure that the governor implemented once we were 2 months into COVID, and changed sort of our operating model. So we are currently evaluating that and trying to find potentially a marriage between the models. We do this, as I mentioned, by doing education, assessment, planning, response, and support services involving public health providers, private medical providers. We have a big hand in coordinating with the healthcare community, public safety agencies, including police, fire, and EMS, and other government officials. So certainly our local and state emergency management agency, the governor's office, our congressional delegation, and others. This is an old org chart. I want to caveat by saying that right now the current org chart is under construction. But just to give you a general sense, the Center for Emergency Preparedness and Response lives inside the Division of Preparedness, Response, Infectious Disease, and Emergency Medical Services, or PRIDEMS. And what I love about this version of the org chart is CPER is right in the middle. And that is exactly where we are. When we had a former director reorganize the org chart, he created centers, and there were originally just 4 centers. Dr. Alexander Scott, our former director, our most recent permanent director, liked the model so much because we had divisions, and centers in the original model were cross-cutting. And so the Center for Health Data Analysis, the Center for Public Health Communications, and the Center for Emergency Preparedness and Response are the 3 that were part of that original model that still exists today. But Dr. Alexander Scott wanted to take that idea of being cross-cutting and integrating across all of the department and embed it in the org chart overall. So as you can see, we have many other centers. And again, there are some new centers that are missing from this org chart, as this is from 2019. But CPER, I believe, should be at the heart of whatever the final version or the upcoming version of the org chart is, because of the type of work that we do. So just to give you a little bit of background on how we got here, before 9/11 and then the anthrax attacks of 2001, there wasn't a dedicated resource inside state and local health departments for emergency preparedness and response, and it was not funded in any specific way by any of the federal partners. But as the as numerous terrorism events occurred. So the Oklahoma City bombings, the Atlanta Olympics bombings, obviously 9/11, as I mentioned, the anthrax attacks of 2001, and in the bottom right-hand corner, we have Ted Kaczynski, who's also known as the Unabomber. It became clear that there were public health ramifications to different types of emergencies. And so after 9/11 and the anthrax attacks in 2001, not only was there a coordinating issue that was recognized very clearly by all of the response partners, but also public health did not have a seat at the table. And so the following year, a significant amount of money was poured into state and local health departments to begin to build a robust infrastructure, both for base public health functions that could be used to support response, but also to create a preparedness and response function on its own. And so for the first several years, we were focused specifically on bioterrorism, and then a number of different events occurred. So on this slide, we see in the upper left-hand corner, I think I can use my cursor here, is this is the Superdome from Hurricane Katrina. And Hurricane Katrina really was the force that changed a lot of the work that we did. So we started out doing bioterrorism. We were also looking at pandemic preparedness because there was an H5N1 highly pathogenic avian influenza circulating in Southeast Asia, and there was concern that that could jump the species barrier from chicken to human and become transmissible human to human with enough evolution. And so we were preparing for pandemics even back then. But what happened during the Superdome event, I'm sorry, I should say during Hurricane Katrina, the Superdome opened as a mega shelter. And Louisiana had done significant planning for this. So at the Superdome, they had a backup generator. The Superdome itself had air conditioning. They had MREs, which are meals ready to eat, as they, consulted with the Army to see what they utilized, for long-term storage. And they had Army cots. And what they didn't consider was all of the things that could go wrong at the Superdome, but also who was going to need sheltering during an emergency. And so they were thinking about the military model, which is very young and fit and active people who are, sent out into the desert in the beating hot sun, but in the best shape of their lives, most likely, and are eating MREs, which are full of salt. And the people who ended up going to the Superdome were all of the folks who you could imagine fall into every social determinant of health. So they were people who didn't have access to transportation to leave the area. They didn't have the funds to buy a plane ticket or rent a car in order to get out, or even to stay in a hotel outside of New Orleans. They were older, so they had more chronic illness, as is just the natural case of things. They were poor. Louisiana has one of the highest obesity rates in the country. So many of them were morbidly obese. And so what ended up happening was, we had people who were there who had high blood pressure and didn't bring, again, they had to evacuate rapidly. So people didn't bring their medications. There was no cache of medications to support them. There was no medical team to support them. They had they were eating this food that was full of salt, which was raising their blood pressure and putting them at high risk for a cardiac event, including, a heart attack or a stroke. The cots were very, very low to the ground. And so folks who were elderly or who had mobility issues were unable to navigate the cots. Those who were morbidly obese either couldn't fit on the cots, or the cots were collapsing beneath them. So it was a screaming indicator that public health needed to be at the table, because folks who work in public health are familiar with all of these planning components and would have been able to hopefully create a better plan. So it's not that they didn't have a plan. I want to make that very clear. It's that they weren't thinking about sort of all of the people who could need to utilize this service. The next photo is of a parking lot full of RVs. So this was another really great plan that was put in place, but without public health input. So FEMA thought, hey, there could be a really large disaster someday and we would not have a place to house people because housing might be destroyed. What if we purchased a lot of RVs and then we could transport them to the impacted area and allow people to live, somewhat independently? And again, if you think about like living in this photo of the Superdome, with 10,000 of your neighbors in an open space. And just to give folks an idea of what happened there, so first the power went out due to the hurricane, so the generator kicked on, but the air conditioning wasn't on the generator. So this was the end of August in New Orleans, and so you could imagine how hot and humid it was. And then the generator failed, and so then they were without any electricity whatsoever. So they had no light or anything. As the waters rose, it breached their wastewater system. So now they had no drinking water, and they had no wastewater, so they couldn't flush toilets, they couldn't wash hands. So people were just going to the bathroom, in areas that they were creating themselves because toilets were full and couldn't be flushed. So all of those things, could cause a secondary public health emergency. And then in this photo, you can see these streams of light. What ended up happening was the roof blew off the top. And so folks needed to be evacuated out of that space. And actually, Rhode Island did receive 107 evacuees who came from the Superdome or from other places where they had been on their roofs and had been rescued and brought to an airstrip that FEMA was running, and then were able to get on a plane and come to Rhode Island, and we housed them many of them for a significant amount of time. But so anyway, so again, if I had to choose between a trailer alone or with my family versus the Superdome, I would pick the trailer probably every day of the week. But the challenge is that FEMA, purchased all of these trailers in advance. They had them all in a parking lot in the where they were storing them, in very tight configurations, and they never opened the doors or the windows. So what ended up happening was there was wood paneling in those trailers, and they are made of press board, which, like any piece of furniture you've ever purchased from Target or Walmart, is made of press board, not real wood. And they use formaldehyde to create that press board and to finish the product. So there was formaldehyde in that paneling, which normally wouldn't be a problem, but the challenge became that it was off-gassing while everything was contained. So people were excited, they got keys, they opened the door, they walked in, and they very rapidly became very, very ill. So now the healthcare system is already overwhelmed, but some people were able to seek care, and they have these people who were at the Superdome who are now coming in, and they have like massive nosebleeds and really bad headaches, blurry vision. And so the initial epidemiology was trying to figure out, like, oh my gosh, what were they exposed to in the Superdome? And what potentially infectious disease could this be? But as it turns out, it was the exposure in the trailers. So again, if public health had been at the table, if our environmental health partners had been at the table, they would have been able to say, you need to open those and air them out, and maybe somebody needs to go in and do an air quality test before we allow occupancy in these spaces. So again, FEMA didn't have environmental health perspective in the decision making, nor in the implementation. So 2005 really changed our world completely to focus on all hazards. So now there is a public health role in all hazards response. And so you can see some of the other things on this slide include the Joplin tornadoes, which tore apart a hospital and required an evacuation down the street to another hospital. We've taken a lot of lessons learned from that response. This is an oil rig explosion, the BP oil explosion. For those of you who are native Rhode Islanders, this is the largest disaster in Rhode Island history, sort of a single day, or what we call a mass casualty, mass fatality incident. This is the Station nightclub fire in February 2003. This is the remains of the nightclub called the Station. This is a photo from Fukushima. So this is what we call a maximum of maximum events in our planning. So this is if you had said before Fukushima actually occurred that there would be I apologize, that there would be an earthquake that caused a tsunami that then caused a nuclear power plant breach and release, nobody ever would have believed you. If we presented that as an exercise scenario, people would have been like, I give up and I go home. Like, we can't even play that scenario out. So this is, again, if you had said that could never happen before it did, we have to always remember in the backs of our minds that as we're preparing, we have to continuously prepare not only for different types of events and the content that's necessary, the actions that are necessary, the partnerships that are necessary to respond to different kinds of events, but that you can have compounding events. And we saw that. We certainly were responding to multiple events simultaneously during the COVID response, just in a much more prolonged period of time, obviously. Food protection, this is an E. coli outbreak that happened across Europe in bean sprouts that took a very long time to track and introduced a new form of E. coli. These are zeppoli in the center here, which are an Italian pastry that are used or enjoyed when celebrating St. Joseph's Day, and very popular on St. Joseph's Day here in Rhode Island. We had an infectious disease outbreak related to a business that was selling them not only in their retail space, but also selling them to other bakeries. And there were several deaths that occurred in nursing home residents who ate these zeppolis because they were already immunocompromised and couldn't fight the infection. In 2010, we had historic flooding. So this is the Warwick Mall, for those of you who have ever been there, but this is, the floodwaters getting through there. So we respond to all different kinds of things. And we are really big proponents of personal preparedness. And so what we have in the bottom left-hand corner here is a zombie. So CDC did a campaign, a communications campaign, to try to capture the public's interest in zombieism and all the television shows and movies and books that capture folks' attention, and got them to prepare for a zombie apocalypse. And by preparing for the zombie apocalypse, you could be prepared for anything. So it's one more twist on that all hazards message. So this is just a sampling of some things that we've responded to in public health in that all hazards realm that really started at that turning point of Hurricane Katrina. I just like to share this and I promise I will not read from the slides in the future, but this vision statement that the Federal Emergency Management Agency, or FEMA, put out a number of years ago, which I think is really amazing and talks about the scope of the work that needs to be done. So it says that FEMA will work to prepare the nation for disasters by encouraging individuals, government entities, and public and private groups at all levels to become informed of the risks they face, to make decisions that help keep people, property, and institutions out of harm's way, and to possess the capability and knowledge needed to act when disasters occur. Now, admittedly, I have not looked on their website. I did not double check this slide to see if this is still their vision statement, so I want to just put that caveat in. But I really love this statement. And one of the reasons why I do love it is because it talks about, there's this perception that, like, we are the government and we're here to help when an emergency happens, or, the government will swoop in and save the day. And I think COVID has really rocked that foundation in terms of people's expectations of government. And there's a lot now of shift in the amount of trust that's put in government. But we've always known that the government will not be there to save you from the minute the thing occurs. And so there is a focus on, if you see the word right here, individuals. So individuals are also responsible. They are part of the preparedness and response paradigm. And so we need people to personally prepare, especially when we're talking about natural disasters, or infrastructure issues like power outages or cyber events, so that they are prepared to act independently and be able to take care of themselves, their families, and their pets, potentially their neighbors, for at least 72 hours. So we encourage people to, we have a slogan that goes, make a kit, make a plan, stay informed. So to build a kit of supplies of food, water, medications, supplies to help you protect you against the elements, potentially like what we call a bug out bag that you can pick up and take with you if you needed to evacuate quickly, batteries, flashlights, etc. And ready.gov is a great resource if anybody's looking for more information on personal preparedness. But we ask people to prepare and then to make a plan, like, where are you going to meet if something happens to your home and everybody needs to rush out? Is there a fire hydrant down the street? Is it a neighbor's house? If everybody's in a separate place or you're at school, what's the plan for reunification somewhere down the line? Who are you going to call? All of those types of things. And then stay informed is, make sure you have a weather radio, something that doesn't require batteries, or you have a lot of batteries so that you can continuously monitor the news should your phone die or, cell access gets knocked out. Do you have a way to get more information about what's happening and how you can take further action? So again, this is, from a very high level perspective, what it is that we are trying to achieve, not only as individual government entities, entities as a coordinated national structure as well, but down to the individual level. As I mentioned, we have embraced this all hazards approach, and this is just, a set of examples of the different types or categories of disasters we prepare for. So biological, both, an infectious disease that is naturally occurring and or a bioterrorism event. Same thing, a chemical accident or an intentional event, a radiological accident or intentional event. Natural disasters are not typically intentional other than by Mother Nature. Mass casualty incidents. So if you think about the shootings in Vegas a number of years ago at a concert, or you think about any of the mass shooting events. If you think about, again, the station nightclub fire or other accidents that occur that impact a lot of people, we do in every 3 years a full-scale exercise at the airport that involves an airport crash or some other event at the airport where people are on a plane or waiting for a plane or trying to get to their family members who might have been involved. And then everything up to the level of a pandemic, which is always a unique situation because the entire world is involved and everyone's competing for the same resources. So as we saw during COVID, the biggest challenges that we had to do with scarce resources at every phase of the event. And then the impacts that had because we didn't have those resources where people needed to isolate. And now we have had, not only obviously the disease process that everyone has experienced, but the downstream effects of having been isolated for a long time, the economic effects of having to shut things down and try to reopen them, and people not, engaging in the economy in the same way. So pandemics are all encompassing and are different. For any of these other types of events, we can share resources across the country or country to country, right? When we had the station nightclub fire, people came from all over the country to help support the recovery of that event, from, additional medical examiners to additional folks who work in the behavioral health response realm. Even in terms of clinical care, we transferred some of the folks who experienced significant burns across state lines to other burn centers. But in a pandemic, we can't do that because everybody's in the same boat and we're all competing. So it's a unique planning and response scenario. So what are the things that we do to prepare? Again, these are very high level points, but as I mentioned, our cycle, and for those of you who are interested in continuous quality improvement, we don't follow fishbone models or lean projects. We do a cycle of planning, both internally. We usually start core inside our team and then bring in other subject matter experts from inside the department and then expand beyond the department. So we go through a cycle where we do planning, then we train on the plan, and then we conduct exercises to test the plan to make sure everything is in functional, I guess. And then, we try to run it against a few scenarios, and then we go back to the plan itself and start over to say, okay, how do we need to modify the plan based on lessons learned from training and exercises? And of course, anytime we have a real world event, we then evaluate the plan after that and then update it accordingly. And that means, again, meeting with internal and external partners and making the cycle run faster. So when we have, gaps that we identify in training, there were parts of the plan that when we tried to implement that didn't work well, we say, okay, we need more people trained on this, or we need people trained in a different way. And we build a training plan around that. And once we've done those trainings, we say, okay, now we need to exercise this and see what works and what doesn't. And we exercise it or exercise it again. So that's just as an FYI, that's really the emergency management cycle, and we follow that very closely. We find it to be very effective, though difficult to keep moving because there are so many different types of scenarios and so many emergency response functions we're expected to perform to keep them all moving simultaneously through this cycle. We work a lot, especially in the beginning with bioterrorism. We worked a lot with clinical partners to ensure that they were trained and ready to respond to bioterrorism events. As you can imagine, during Ebola, there was, although we had very few cases in the United States, as we were watching that outbreak occur, there was a significant amount of PPE that needed to be acquired. I'm sorry, PPE is personal protective equipment, and folks needed to be trained on it. So we were, doing intense training as well as exercises. We did what were called no-notice drills by going to every hospital. Surprise, here we are, acting out a patient scenario and taking them through a several-hour drill to ensure that they had all of the right components in place from the moment a person walked in the door, to ensure that they were isolated, that the appropriate notifications were made internally and externally, and that and that they were able to provide appropriate assessment and care to those individuals for the first 24 hours. So we did that again with COVID. You know, many of our partners had never used personal protective equipment or used, gloves and occasionally a regular mask. And so, we had people who had to wear N95s and other things while they were, while they were responding, and that was new to them. So it was a lot of training on PPE and other things in order to ensure that people could be protected and safe. We also have a network of laboratories, and I'm not sure if this has already come up in a different Public Health 101, but we have what's called the Laboratory Response Network, which is our state health laboratories and their multiple functions, and then hospitals and other commercial laboratories who respond together to different types of emergencies. So we have all types of drills and exercises that we conduct with them on an annual basis to ensure that people maintain competency in testing for things that are not the tests that we do day to day, and also just the packaging and shipping of samples and specimens back and forth, and labeling and all of that fun stuff that can make or break an initial response. We have a lot of emergency communications networks, both from a public information perspective, so you can imagine traditional media, social media, and others, as well as tactical communications. So I'm sitting here, and I have two phones in front of me. One is my work and one is my personal, but I use them both for work constantly. We have radios, we have satellite phones, we have satellite systems, and a host of other online, software-based, internet-based functions that we use to communicate with our partners in the day-to-day and during an emergency. And I'll show you a couple of those later on in this response. It's also our responsibility to try to teach the public what to expect and what they can do to prepare. So it is, almost mid-August at this point in time. September is National Preparedness Month. So to those of you for whom preparedness is new, I would encourage you to, follow ready.gov, follow the Department of Health. We do a social media campaign in that time frame to try to get people to take just small steps at a time to begin to prepare. I will tell you on a personal preparedness note, if you take the deep dive and you say, I'm going to do it all at once, you're going to become incredibly overwhelmed incredibly quickly. So I would say, I encourage people to take small bites and to, every time you go to the grocery store, buy one item, buy one box of granola bars, buy one pack of batteries, buy one, case of bottled water when it's on sale, just one thing. And if you just spent a few dollars every time you went to Target or, the grocery store, then very quickly you could acquire all of the things that you need. But if you decided to put it all in your shopping cart all on one day, it will feel overwhelming because it can cost a lot of money. If you are interested, we do have some resources. I have my own personal kit that I have in the past put on display so that folks can see it, touch it, and we have a spreadsheet about what are those different items and where did I get them and how much did they cost. And again, cost is probably different now than it was a few years ago when we started this project due to inflation, but it would just give you a general sense. So if anybody's interested in that, please feel free to reach out to me and I can share that with you. The Center for Emergency Preparedness and Response, or CEPR, is unique in the department because it is one of the very few areas of the department that is 100% federally funded. So we do not receive any state funds to do the work that we do. We are primarily beholden to the CDC for what's called the Public Health Emergency Preparedness Cooperative Agreement, or we call it PHEP, and then the Hospital Preparedness Program, HPP, which is part of the now Administration on Strategic Preparedness and Response, which is inside HHS, the U.S. Department of Health and Human Services, at the highest level. And so you can see, we get approximately $7 million a year to do the work that we are doing. A lot of that money, it goes to support our external partners and the work that they are doing. We also get supplemental funds related to emergencies when they are occurring. So, we got COVID funds from both grant sources very early in the COVID response. We have received significant funding for, H1N1, Ebola, Zika, the Ebola funds, we had a 5-year grant related to Ebola that we spent a lot of time working on and had a lot of requirements that go along with that. So that's the other thing I would just like to say for those of you who haven't navigated the grant world yet, and if this is an emerging part of your career, public health is primarily, approximately 80% grant funded here in Rhode Island, but the every grant comes with a lot of requirements and in terms of reporting and a lot of restrictions in terms of how you can use the funds. So often you'll do an assessment, a needs assessment, and you'll say, here are the things that we need to do, but you'll only be able to do a slice of them because even though you might have more money than you need for the slice that's allowable, you have to figure out how to navigate all of that because how we operate at the state and local level is different than at the federal level. And you also have to remember that our federal partners have to create grant programs for every state, and not every state is the same. They sometimes forget about that. So just a heads up, a little highlight into public health overall. So again, when we get these specific funds that are related to our whatever the emergency happens to be at that time, it often is not just a bucket of money that we can use for anything. It is typically money that is earmarked for specific things and or because of the reporting requirements and the things that you're required to report, it drives your activities in those directions. So that is how we are funded. When I first started in the department, there was no Center for Emergency Preparedness and Response. The two grants, one was in the Division of Environmental Health, the Public Health CDC grant was called the Public Health and Bioterrorism grant at the time, it came into environmental health and was administered there, even though it was cross-cutting. And then the hospital preparedness program was embedded in a division of health services regulation, which has changed dramatically over time, would now be considered actually part of policy information and communications, or PIC. So we are, and things have, changed radically over time. But in 2006, Dr. Gifford came in and he's like, I don't understand why these two things are in two different divisions. Let's make them one thing. And oh, by the way, as I mentioned before, that cross-cutting nature of the work that we do, we're going to change the structure altogether. We're going to create centers so that they cross-cut across divisions and better represent how the work is performed. So that happened in January of 2006. So to give you a sense of the different topics that we are required to address as part of those grant funding opportunities, each has a set of capabilities that we are required to address. And the capabilities, I want to be clear, are not necessarily tied only to the funding. They are a requirement that we address them as part of the funding, but is also the expectation that public health and our healthcare system partners as a whole are addressing them outside of just the funding that we are receiving. And so we have 15 capabilities on the public health side, and we have 4 overarching capabilities on the healthcare preparedness and response side. So we spend a lot of time tracking the activities that we're doing according to these different capabilities, but just like the center is very cross-cutting, so is the work. You very rarely talk about infectious disease. Let me go back one slide. When we talk about planning for an infectious disease, there's a preparedness component, there's an emergency operations coordination, that's like how we activate and respond. There's emergency public information and warning. There may be special considerations for how we're going to manage fatalities. We have data that needs to be shared, and so all of our information systems are addressed in this capability. If we're having, like we did during COVID, we opened shelters, during storms, or, heating and cooling shelters at different points during the year. That's under mass care. So we had to provide public health guidance to ensure that folks could congregate safely there. Medical countermeasure dispensing administration is, how do we get out vaccines or antibiotics or other medications when something is happening, or even PPE is considered a medical countermeasure. So, masks, gloves, etc. How are we going to get those to people? Medical material management and distribution is our warehousing function. And again, how we distribute all of that stuff. This is more, the first one is about dispensing, and this is more about the distribution so that people can dispense it. Medical surge happens in any infectious disease event, so we need to be monitoring with our healthcare system partners what's happening in primary care, at our health centers, at the hospitals themselves, what are hospitalization rates versus ED visit rates, etc. Non-pharmaceutical interventions is, for us, like like, masking or quarantine and isolation. All of those, all the planning, training, and exercising that we do there is part of non-pharmaceutical intervention. The public health laboratory, always an integral part of an infectious disease event, because we need to know what we have and what we don't. And then surveillance and epidemiology, these two things are very closely tied. Responder safety and health has to do with whatever measures we're going to take to protect folks who are on the front line, including our health care workers, including police, fire, and EMS, and sometimes the department itself, public folks who are working in public health who then have to go out in the world after a storm when power lines might be down and there's a lot of debris, or, again, in an infectious disease event when they're going into a nursing home because there's a significant problem that needs to be assessed and addressed. And then volunteer management. We have a really wonderful partnership with our the Rhode Island Medical Reserve Corps and Disaster Medical Assistance Team, who do a ton of volunteer management for us. And they're not the only entity who does, but we do contract with them to ensure that we have what we call force multipliers. We have other folks who can support public health response. And so they are able to garner significant numbers of people to help us. Just last weekend, vaccinate 391 people against monkeypox. They were able to set up, 2 clinics very quickly and run, close to 200 people through each of those. So we rely very heavily on volunteers, but also on a system and a process and partners who make all of that magic happen. They check licensure, they organize the events, they recruit people to be part of the team, but also at the time of the emergency to to go to those 2 clinics, as I just mentioned. They do all of the logistics associated with it. So it's a significant lift there. So just to to use COVID as an example, because we used every capability there. And then with our healthcare system partners, very similarly, a lot of those activities are baked into these 4 components, but obviously ensuring that we are ready to respond. We have a coalition, the Healthcare Coalition of Rhode Island, which is a grant requirement on the hospital preparedness program side, where we bring folks together to create a plan and then conduct joint activities across the healthcare sector for, again, planning, training, exercises, and real world response. But it creates an opportunity for us to share resources among each other, either during planning, training, and or exercising and response, to create situational awareness across the healthcare sector, both from a government perspective so that we have a high level understanding of what's happening, but also so that they understand what's happening in other facilities. We need to ensure that they are prepared to continue to provide healthcare when they get overwhelmed, whether that's because we have a single significant, one-day mass casualty incident or a longer-term event like COVID, trying to ensure that they can continue to deliver their services or like if something goes offline, if we had something happen at one hospital, how do we ensure continuity of services to those patients in other places? And then medical surge. All kinds of things can cause medical surge in any part of the healthcare sector. So we talk about, something that happens in the field that EMS needs to respond to. What do they do and how do they get, ambulances to a mass casualty incident in a coordinated way and then transmit information back to our hospitals? Then the EDs surge. They may need to cancel surgeries. They may need to call in additional staff. Again, just talking about the many different scenarios and the differences that go along with implementing any of those scenarios that cause medical surge. So for all of that humongous scope of work, and again, while it is cross-cutting, this is the org chart for our center. And the light green boxes are positions that are filled. The dark green boxes are those that we have FTEs for but are vacant. And then these positions along the outside here are positions that are contracted or seasonal employees. So I left the names on here so that you could see some folks who you likely have already met, or if you haven't, so that you have access to their names if you have specific questions about specific programs. And because we fund through PHEP an emergency communications coordinator position, so Anna Tomasulo actually works in the Center for Public Health Communications, but provides communication support to all of the programs here in the Center for Emergency Preparedness and Response. And then we have a person who we call our CEPR +1, who is Dawn Lewis, who is here today. And she is a contracted partner through the Hospital Association of Rhode Island. She co-chairs the Healthcare Coalition of Rhode Island with whoever is our Healthcare Emergency Management Director, or as we call HPP coordinator, who at the moment, Phil Sheridan, who is the CEPR deputy, is filling that spot while this position is vacant. But is really, Dawn is very much embedded in our day-to-day work because there is so much overlap in terms of the public health and healthcare system preparedness and response. What CEPR is not. So there have been rumors in the past, I hope everybody knows what a Jack in the Box is, but that our team, sits in the basement. The core of the team on the program side does sit in the on the lower level, kitty corner to the print shop, for those of you who have been there, and the think space, and on the other side of our door is the think space if you've ever been there. But there are people who believe that we just sit around and wait for emergencies to happen, and then like a Jack in the Box, the emergency happens and poof, we pop out of the box and we run into to respond to the emergency. And we could not be A, that's untrue. And B, we could not be successful if that model existed, because then we wouldn't have the partnerships that we rely on in order to make the responses occur. We wouldn't have, the plans or the training behind us in order to be able to actually mount an effective response. So just because we get highlighted when an emergency is occurring and people typically see us on the front line, inside the department front line of an emergency response, does not mean that that's the only thing that we do. So I like to just share this so that people, embed it in their mindset that we are not CEPR in the box. We have responded to hundreds of emergencies. And so I'm just going to click very quickly through these slides. I just want to orient you to the colors. So blue is a weather emergency, red is an infectious disease emergency, and black is typically, a mass casualty incident or an infrastructure issue, just to give you the sense of over time how this changes. So you can see, we started, when I began in the department in 2004, things were sort of infectious disease heavy. Then we started to have all of these storms that we were called up to support. This is a photo. I mentioned we received 107 evacuees from Hurricane Katrina. This is a photo of the tarmac at Quonset where that plane was coming in. You can see over here, sort of just left of center, is the mobile command center from the Rhode Island Emergency Management Agency. But if you look across, you see a lot of people wearing different vests and different colors. This was a very large scale statewide multi-agency response that we implemented in order to safely receive those folks and provide them with all different types of supports, because everything had been taken away from them. They lost family members, they lost pets, they lost all of their belongings, and they needed to essentially start over in a brand new place. So this is, again, just to highlight that we are one significant but small cog in a very large machine when we talk about emergency preparedness and response. We've had a lot of very unique scenarios, and very early on, we responded even to small events utilizing the incident command system, which is the structure that we typically use to respond to emergencies, so that we could create muscle memory, so that we could learn the process together before things got incredibly complex. And this really worked to our advantage. As you can see, this particular outbreak, which turned out to be a norovirus outbreak, it was at a father-daughter dance in Woonsocket. But we were investigating whether there was something malicious that had occurred, or and what the disease process was, and therefore how it could potentially spread. But we had these very sick, kindergarten and first grade young ladies and their dads who were all home vomiting, and the moms were very unhappy. So again, we used the incident command system to respond to this, and it was a very short duration event. It was only a few days while we did that investigation, all the laboratory testing, all the public information and communication, all of the data collection and sharing, as I mentioned earlier when we talk about capabilities. But it really helped us begin to build a strong understanding of how to respond to an event internally as a department. We then had, in 2006 into 2007, a very significant outbreak of Mycoplasma pneumoniae, which is actually walking pneumonia. It's not that uncommon, but it occurred outside of the normal pneumonia season, and people got incredibly sick. They had neurological illness, which is not typically associated with pneumonia. So we actually brought in a team from CDC to help assess whether or not this was a unique strain that we needed to be concerned about, because we had these young children from several schools who were experiencing these severe neurological events and were in the pediatric intensive care unit because they were so sick. So fortunately, there was not a new strain. We never really got a great explanation for how or why this occurred, but fortunately it was somewhat self-limited. But so sometimes we have, local news attention, sometimes we have national news attention. We had a very large outbreak of tuberculosis at Central Falls High School. This is, an example of something that lasted a long duration. If you've ever been tested for TB, after an exposure, you get an immediate PPD planted, and that it gets read within 48 hours. And then for several months, after several months, you have to get tested again. And then at the 6-month mark, you have to get tested again just to see if anybody has converted. So this was a long-standing event. This is the first time I ever served as incident commander for an event here in Rhode Island. But then just as we were wrapping this up, we had a pediatric surgeon who ended up actually passing away. He developed TB as well, had been operating on patients because he thought he just had, some mild respiratory illness, and ended up exposing a lot of kids in his surgical practice. So we had to re-up everything and respond again. So sometimes even when you think it's over, it's not over. The 2010 floods were the most significant natural disaster we've experienced here in Rhode Island. The damage was outrageous. This is right actually near where I lived at the time in West Warwick. As you can see, all of the flooding that occurred. This is on Providence Street in West Warwick, but there were huge economic impacts, huge behavioral health impacts. People lost so much. We didn't have any significant fatalities, fortunately, but there was a lot of recovery work. And so sometimes, you have the immediate event and you do the immediate response like we did, which is for a few days, but then you have this very long recovery phase that is also part of emergency management. This is the consequence management side of things that we're dealing with. And can take a very long time. Obviously, when there's a lot of clean out and reconstruction, and assessment has to happen before any of that can occur. We have to get the money, all of those kinds of things. These are projects that get funded by the Federal Emergency Management Agency and are open for years, if not in some cases decades. So again, over time, we've had more and more disasters that just continue to keep us incredibly busy and allow us to test our plans and again identify new opportunities for training and exercises. These are just some of the events that have occurred since 2020. So the Crestwood Nursing Home fire was in early January of 2020. COVID-19 we activated January 31st of 2020, our full incident command structure. We were already meeting by mid-January as a leadership team to talk about what was happening in other parts of the world and what preparedness activities we needed to do. So everything that has happened beyond that has happened essentially during COVID. So we had a nursing home strike that on the day before they decided not to strike, but we still had to do all of the preparation for what was going to happen if we had multiple nursing homes that did not have their staff. And how we were going to respond to keep those folks safe, and trying to think about, nursing homes and assisted livings during COVID and having to move folks around was very daunting and dangerous, especially in 2020, before we had vaccine, before we had, even at the time that the nursing home strike was occurring, we were still in the acquisition phase to have enough PPE to provide for everybody. So the thought of moving people during this was very difficult. We had 2 tropical storms. We had a fire during a heat wave at another nursing home that required a partial evacuation. We had, 2 winter storms, and this winter storm Keenan, the respiratory rehab fire, and winter storm Oakley all happened within 30 days of each other. So it's a lot for the team that works on the healthcare the healthcare preparedness and response side of things, this was a very, very busy time. It was early 2021, so we were in COVID and doing all the things responding to COVID. We were actually in the Delta Omicron phase of COVID. So things were very, very busy. And then we had these 3 events happen, all within 30 days that required our time and attention. We had a radiation incident recently that just closed. There was some radiological material that was identified coming out of a house cleanup that, in a dumpster that arrived at a transfer station that activated a response by RIDO and a number of additional partners, and fortunately did not have any widespread exposure, but certainly had our concerns up and running. We have monkeypox right now that many of us are very actively responding to. In case you're not familiar, as part of our emergency operations plan, we have this precursor to the incident command system, which is a management structure called a task force. So we are currently in monkeypox task force at the moment, and we are operating virtually at this point in time because folks are, in the office on different days. But again, it just creates a small leadership structure, but a multidisciplinary group of people who come together to try to address what's going on in the initial phases of the event. So we haven't yet hit a trigger that would force us to move to the incident command system, but we are evaluating if and when that needs to happen. And then just a few weeks ago, we had a flood in a pipe burst in an assisted living facility overnight, and we had to partially evacuate that facility. It happens to be an assisted living that specializes in memory care, so folks who are in the early phases of dementia and Alzheimer's. So you can't just put those folks anywhere. It's not just, like, hey, do you have an open room? There's additional supports that are needed. And so we got to spend a few hours overnight helping place those folks in other locations so that they could be safe. And because of the damage that was done to that facility, some of those residents are still in other places. So again, no shortage of excitement, no shortage of work at any given time. When we are responding, this is our Department Operations Center. It's on the lower level. If you haven't ever been there, feel free to pop your head in. But this is where we typically operate when we are in an emergency response. We started here during COVID, and then the governor implemented a new response structure, so we got pulled out. And then folks were working remotely as well. So we are going to have to reassess exactly how and when we use the dock because it is, we have a whole new model that may come to bear, given that now we have so many tools to help us respond and support virtually. But you can see some of the CPRites also in the photo over here on the left. Wave to them if you see them. This is just a quick photo of the State Emergency Operations Center. This is when it's a statewide emergency, we get activated. So especially when we're talking about natural disasters, we support what's called Emergency Support Function 8. You can see some of us up here right in the front. This is where we are assigned our seats. But this room essentially fills with subject matter experts from across the state. Some are state agencies, some are local agencies that represent others. But this is where all of the coordination at the state level occurs from a high level. Again, we now have a virtual function to support this when we need to, as we did for several of those storms I showed on the 2 slides ago about natural disasters. We also have a significant amount of supplies that we've stockpiled over time to help support all hazards. Obviously, a lot of that changed during COVID because so much more PPE was acquired. So some things got cycled out, some things were disposed of, some of it was what we pushed out immediately. And a lot of new stuff has come in, and we've actually shifted from one warehouse to another. But our core team maintains proficiency in order to be able to work in the warehouse whenever is needed. So these are just some photos of some folks, again, you may have seen, who now work in other parts of the department. This is Dave, who is on the CPR team, but Chris Goulet is the division director for Pridums, and she used to be on the CPR team. This is Kristen St. John right here on the forklift. She currently works in CHATA. So we have some really great people who have a lot of different levels of training and experience sprinkled throughout the department, for which we are grateful. And as I mentioned, we do a lot of exercises. So same color schemes apply, but just to give you a general sense of how many different types of exercises we are doing, this is not even a complete list. It needs to be, we need to go through with a fine tooth comb. We have several coordinating documents. But they just, we are required to continue to do them. So we keep on keeping on. Several members of the department last week participated in and or observed with an exercise called Operation Milkman, which was a radiological response. As you can see, radiation has become a very popular topic for us, both because we respond and we plan, train, exercise for a nuclear power plant event in Connecticut or Massachusetts, because we don't have a significant nuclear power plant here in Rhode Island that we have to follow the same Nuclear Regulatory Commission requirements for. But we are also required in this particular grant year to address radiological response with our healthcare system partners. So it's also been an area of focus for us. But as you can see, we had a lot of exercises, here, all of these were in 2019. COVID Run was an exercise early in COVID to make sure that we had some of the capabilities that we thought we were going to need. And everything else here has happened, during, as you can see, some of the dates here, these are in chronological order, but, have happened during COVID. So just because the emergency is happening doesn't mean that we don't still have additional work that needs to be done. Operation Thunderstruck is the largest exercise that we have hosted and run. This was a pediatric burn and medical surge exercise that we conducted statewide with all of our hospitals, that involved a scenario where kids were at a camp outdoors and there was a very quick moving thunderstorm that came through. And so they sort of shoved all of the kids into a nearby building, and lightning struck the building and caused fires in multiple locations. And so it started, again, at the scene with our EMS partners, and then all that communication back to hospitals, and then the coordination with the hospitals, as well as trying to ensure not every hospital is a pediatric or a burn specialty hospital. So again, assessing supplies, resources, knowledge bases, and additional training needs was really one of the drivers that came out of this exercise. So that helped us build a plan for moving forward for future planning, training, and exercises related to that scenario, and again, the individual components within. Sometimes exercises look like this. It might be just an easy communications drill where we're testing to make sure everybody's communication equipment is working and that people know how to use that equipment. Sometimes it looks like this. This is a photo from an airport exercise we did several years ago, where we have what's called moulage, which is, makeup and these, sort of artificial limbs. As you can see, this is designed to look like this woman lost her foot. This is fake. But again, so that first responders have something to respond to. It kicks in your adrenaline when you see it, as opposed to, sometimes we do it and where someone's just holding a piece of paper that says, here's what happened to me. This makes it, look and feel a lot more real for people, and helps assess their skills to be able to triage and treat folks. Exercises require evaluation. So at this particular exercise, these are 3 members of the team who were evaluating an exercise that was occurring. You see Dave here with his clipboard. Sometimes they look like this. This is an exercise that we did that included the State Health Laboratories and the Rhode Island National Guard Civil Support Team. So there was, again, a scenario where there was something that was causing a significant illness. And so because it was so toxic, they had to call in a hazmat team, essentially. But we utilized, because there's a partnership between the lab and the civil support team, and the civil support team had the resources, they were able to come in and do the assessment and do the appropriate testing. This was also an opportunity to ensure coordination between the CST and the lab in their capabilities. Lingering here in the background, for those of you who haven't met the amazing Cindy Banner, she has been the acting division director for the past several months for the Division of State Health Laboratories and the Office of the State Medical Examiners. She is the chief operating officer for that entity, as Dr. Gallagher has just come in, or is just starting, I believe, next week as the new division director. But she's a longtime member of the department and used to run the bioterrorism and special pathogens lab at the department, which is now run by the fabulous Toby Bennett. If you haven't met them, definitely make it a point to meet them. They're outstanding at their work, but just as humans as well. Sometimes exercises look like this. This is what we call a functional exercise. So we activated and had a central command center here in the Department Operations Center. And this happened to be a health center exercise. And so we had folks who were, I'm sorry, this was, I think, hospitals and health centers. So we had, the command centers in all of those other locations activated, and we were asking them to provide us information as they were responding to a scenario. Sometimes they look like this. I use this one because it's fun, but this was for the School of Pharmacy at the University of Rhode Island hosts a course that teaches folks how to do mass dispensing, teaches pharmacy students how to do mass dispensing. And so this was, again, a zombie exercise to sort of capitalize on people find zombies to be fun. And so they were handing out a drug called zombie cycline to help prevent folks from getting zombieism. And so these are some fun photos of that because they had actors from their theater program who showed up as zombies. And this, the pool noodle that you see right here was a zombie catcher. So they really went all out in order to make it fun, but it helps, embed that information in your brain about what you learned. As I mentioned, none of this is possible without our internal and external partners, and the list of external partners is incredibly long. We work with everybody for the most part in the healthcare sector, as well as their trade organizations. We work with behavioral health partners, with state and local emergency management, state and local police, fire, and EMS, environmental management, the Red Cross. As I mentioned, Rhode Island Responds is our volunteer management especially for volunteer health professionals, but also all of the folks who support those missions where we need public health and medical support. The Rhode Island Association of Emergency Managers is a partner of ours. They're having their annual conference tomorrow, and we will all be there, as well as the other people who do my job throughout the country, but especially inside the region. Because New England is so small, I'm in frequent contact, especially with my partners in Connecticut and Massachusetts, because things that happen here happen there as well. There's constant overlap. So we stay in close contact so that we can compare notes and ask questions of each other, and sometimes, our emergencies require evacuation of a facility that could go over state lines, or, infectious disease that's creeping over state lines. So it's a really strong and wonderful partnership. The other big tool in our toolbox, as I mentioned, is our online electronic systems. So just very briefly, we have a public health emergency management suite that has the hospital capacity system. This is live in every hospital ED 24/7, can also be turned on in every hospital command center. And it's where we are able to share live information immediately with the entire hospital system. So we can blast out alerts, and there's an audible alert on all of those computers that says HCS alert message, please respond. And it just keeps repeating that until somebody looks at it and acknowledges it. And so we can ask for bed counts for the emergency department. We can ask for specialty bed counts if we need to, know how many ICU beds or pediatric beds or, burn beds, whatever the case might be. We can ask for those things. We can sometimes it's just information sharing to say, hey, this is coming, or hey, it's 4th of July weekend. Don't forget, that the forms for, fireworks injuries are in the resources section. This system also talks to on the right. I'm sorry. This is the hospital capacity system here on the left, and on the right is a screenshot from the patient tracking system, which we use for every patient every day in EMS. So if you call 911 and an ambulance responds, they slap a bracelet on you, they scan it into this system, and then the information gets transmitted to the hospital that you've decided to transport that person to, and that allows for hospitals to have a knowledge and understanding of who's coming and what kind of care they might need. It gives hospitals time to call in additional resources or specialty resources as necessary. And it also provides an opportunity, if they need more information from the field, either EMS or the hospital can request a call from the other so that they can share information. We also use this information at the state level, we can see all of the patients who are in the patient tracking system at any given time. So if we have a mass casualty incident and we have folks who are scattered to the hospitals around the state, we can see who went where so that we can support family reunification and to, know and understand the scope of the event and how many people were transported. We have a long-term care mutual aid plan with all of our nursing home and assisted living community partners that allows for the sharing of resources, whether that's beds, staff, or stuff, as we like to say. But this is the, when the tool is activated, this is the main dashboard where we can look to see, have we received reporting from all of the facilities, or do we require, some additional follow-ups? How many beds we have available and where, what types of transportation resources they have inside the community that we could bring to bear, and who's having, as you can see, like these red and yellow bubbles, who's having operational issues that we may need to address. Typically we use this when we're talking about a storm that causes a power outage or other things. But this is the dashboard that we use. So all of the partners are able to just get on very quickly and report their information. If their internet is down, we can report for them, if they call us on the phone or the radio. And so again, it just gives us great situational awareness about what's happening, and we feed that information both up and out, to maintain situational awareness of what's happening in the long-term care community in an emergency. And finally, we have the Rhode Island Special Needs Emergency Registry, which is a voluntary registry for individuals who may need additional assistance during an emergency. Folks can voluntarily register, and then that information is shared with their municipal emergency management agency, as well as E911. So if you call 911 from the phone number that's registered in Risner, a box will pop up that's, for the dispatcher at E911 that says, someone at this phone number, utilizes oxygen, or, has a mobility challenge that requires the use of a wheelchair, or, whatever the case might be. There's a prompt that comes up so that even though you might be calling 911 about somebody else in that household, at least they have an immediate heads up that they could need some additional support, if they're responding to the patient who's registered. So we utilize this also during emergencies, like ahead of a storm. Municipalities will pull down all of their information so that they have access to everybody's names, addresses, and phone numbers, and what their needs might be. People download the list and then send out emergency notifications to those folks via email, text, and phone. If they have special messaging that they want to let people know about in terms of, a shelter is opening or a cooling warming center, or if you need additional assistance evacuating, please call back at this phone number. So again, it's a really amazing tool. We have a lot of systems that are utilized to keep the data as clean as possible, so that responders aren't going somewhere where someone may no longer live. We want everybody to be as safe, and when resources are available to help, that they can get the help that they need. We use this significantly during the Newport gas outage in 2019, and have made a lot of changes since because of the tremendous lessons that we learned during that event. I've already talked about our partners at Rhode Island Responds, or as we call them, the DMAT MRC, so I'm going to skip that. But I realize that we are already 9 minutes over, and my last slide is about questions. I have time if other folks, do have questions. I would be happy to answer them. Or I'm happy to let everybody get on with their day. My contact information is here. That is I do sit in room 105 in the Cannon building. If anybody's ever interested in popping by, I'm in on Tuesdays and Wednesdays most of the time. But feel free to email me at any time if you would like to, ask questions or learn more. We would be more than happy, to engage in future conversation. Thanks, everybody. I appreciate your time and attention.
Thank you so much. This is great.
Thanks, Jen. Have a great day, everybody.
Too.